Hello, my name is Gail Herrine, and I am an obstetrician gynecologist and an internationally board certified lactation consultant. I'm here today to talk to you about why breastfeed, the risks of not breastfeeding. We are here at ABM because we want to support breastfeeding efforts among our patients, our colleagues, in our workplaces and schools. Hopefully, you will be having many conversations about breastfeeding moving forward. These conversations can take many forms. It could be an elevator speech given to a hospital administrator about having one or more lactation spaces available to express breast milk while employees are working, or it could be a plan for educating patients during the course of their prenatal care. Or it could be a lecture to medical students, residents, or colleagues. In order to have these conversations, you need to have some facts at your fingertips. During this course of what every physician needs to know, we want to give you these facts. The discussion about breastfeeding during pregnancy is an important one for the practitioner providing obstetric care. Most patients decide how they're going to feed their child by the first or second trimester, so the conversation needs to start early in prenatal care. Discussing breastfeeding during pregnancy certainly is important, but having a discussion as a girl is becoming a woman or at a GYN annual visit while performing a breast exam may be another good time to plant the seed about what the physiology of the breast is all about. I often do this during the breast exam. So while I'm doing the breast exam at an annual visit, I might say, a breast exam is a good thing to do to your breasts, which are mammary glands. They may respond to the hormones of your cycle. You may notice your breasts, the glands respond to the hormones, and you may get some tenderness before your period. And that's normal. I just plant the seed to let them know the breasts are there to make milk. We often think of breastfeeding surrounding pregnancy and the peripartum period. Women have healthcare needs beyond their reproduction, and lactation needs to be considered when providing this care as well. Any physician caring for a childbearing age patient with breasts should be asking about whether they are lactating, as this may affect the treatment and care plan of the patient and a choice of medication. Therefore, all physicians need to be aware of the reasons to and how to support breastfeeding in their patients. Traditionally, we talk about the benefits of breastfeeding, and most scientific papers discuss the benefits of breastfeeding. However, as Dr. Stubbe points out in a 2009 discussion about this topic, although mathematically synonymous with reporting the risks of not breastfeeding, this approach implicitly defines formula feeding as the norm. This subtle distinction impacts public perceptions of infant feeding. In 2002, the United States Ad Council conducted focus groups to develop National Breastfeeding Awareness Campaign, targeted at reproductive age women who would not normally breastfeed. They found that women who were advised about the benefits of breastfeeding viewed lactation as a bonus, like a multivitamin, that was helpful but not essential for the health of their infant. Women responded differently when the same data were presented as the risks of not breastfeeding, and they were far more likely to say that they would breastfeed their infants. Discussing human milk as the norm and not a bonus or the best is another good way to form your discussions around breastfeeding. Health outcomes differ substantially for mothers and infants who formula feed compared to those who breastfeed, even in developed countries such as the United States. All this being said, most papers are not written as the risks of formula feeding, and trying to simply invert the data is not mathematically accurate. So I have referred to the benefits of breastfeeding today when I'm speaking about the actual facts. Exclusive breastfeeding is defined as the provision of no other liquids or solids besides breast milk unless medically indicated. Even beyond 12 months, it's estimated that breast milk provides 35 to 40% of the energy needs between 12 and 23 months of age. It has been documented that in societies where children are allowed to nurse as long as they want, they usually self-wean by 3 to 4 years of age. Studies and meta-analysis have also confirmed the impact of breastfeeding longer than 12 months on maternal health. However, mothers who breastfeed beyond 1 year need support. They often report feeling ridiculed or alienated in their choice and conceal their breastfeeding behavior to minimize unsolicited judgment and comments. There is evidence that only half of mothers who breastfeed past 1 year discuss their decision with their pediatric provider, and that 38% of women who reported their provider was unsupportive of breastfeeding past the first year elected to change the pediatric provider. So why breastfeed? Because it's good for the baby. So let's get into the weeds a bit about some of the data of the benefits of breastfeeding and the risks of formula feeding. The Academy of Pediatrics policy statement from the spring 2022 is a very comprehensive document and chock full of data. I will not be going over all that information in detail today. I just have some highlights here. In general, for most disease processes, more exclusivity and longer duration of breastfeeding improve or increase the risk reduction. Studies and meta-analysis have confirmed that 6 months of exclusive breastfeeding was associated with decreased lower respiratory infections, severe diarrhea, otitis media, and obesity. A meta-analysis showed that less than 6 months of exclusive breastfeeding was associated with an abnormal microbiota, and that differences in gut microbiota persist after the first 6 months of age. For lower respiratory tract infections, they are decreased by 19% for babies that are breastfed exclusively for 6 months, compared to babies exclusively breastfed for less than 4 months. Severe or persistent diarrheal illness is decreased by 30% for exclusively breastfed babies. However, Crohn's disease is decreased by 80%, and ulcerative colitis decreased by 79% for children breastfed for 12 months. For otitis media, the risk is decreased by 33%, comparing babies that are ever breastfed to never breastfed. But for babies exclusively breastfed for 6 months compared to babies never breastfed, then the risk was decreased by 43%. There are many studies looking at childhood and adult obesity in people who are breastfed. Overall, childhood obesity is decreased by 20% for babies exclusively breastfed compared to non-exclusively breastfed. For asthma, there's a decreased risk of 22% comparing longer versus shorter breastfeeding, shown to be the most protective in the first 2 years of life. Any duration of breastfeeding beyond 3 to 4 months is protective against wheezing in the first 2 years of life, and this effect is irrespective of duration of exclusivity. There is some evidence that longer duration of breastfeeding, as opposed to less breastfeeding, protects against asthma, even after 5 years of age. Leukemia for babies ever breastfed is decreased by 11%, but for babies breastfed for 6 months, the risk reduction is 19%. The risk of eczema in the first 2 years of life is decreased by 26% for babies exclusively breastfed for 3 to 4 months, compared to those breastfed for a shorter duration. For SIDS, this is probably the most significant change with the talking about duration of breastfeeding. So for SIDS, the risk is decreased by 40% for babies who are breastfed 2 to 4 months, 60% for breastfed for 4 to 6 months, and 64% if breastfed for longer than 6 months. For type 1 diabetes, there is a 57% decreased risk comparing exclusive breastfed for 6 months with never breastfed. For type 2 diabetes, the risk reduction is 33% comparing ever to never breastfed. Why breastfeed? Because it's good for the mother. For the mother, there is a 32% lower risk of type 2 diabetes comparing longer breastfed to shorter duration. There have been many studies looking at breast cancer risk reduction, comparing different durations of breastfeeding. Uner Munguia found that for every year of breastfed compared to no breastfeeding, there is a decreased risk of breast cancer by 28%. Ovarian cancer showed a decreased overall risk of 30% comparing ever to never breastfeeding. When broken down to duration, there is a 17% lower risk comparing less than 6 months to none, 28% comparing 6 to 12 months to none, and 37% comparing greater than 12 months to none. For endometrial cancer, there is a lower risk of 11% comparing ever to never breastfeeding. For hypertension, there was an 8% lower risk when comparing less than 6 months to no breastfeeding, and increases to 13% if breastfed continues for 12 months. Thyroid cancer showed a 9% lower risk comparing ever to never breastfeeding. Breastfeeding makes for a closer maternal-infant bond. It is less expensive than having to purchase formula, bottles, and nipples. Breastfeeding assists with postpartum weight loss. It does not help with overall maternity weight loss. It's not going to cause an obese woman to become super thin and skinny, but it will help with getting off the weight gain during pregnancy. Breastfeeding helps with spacing of children if breastfed exclusively for 6 months, as long as the mother has not had a menses yet. It helps with uterine involution and blood loss immediately after the birth. Why breastfeed? Because it's good for all of us. As discussed in the previous couple of slides, breastfeeding leads to a reduction in largely preventable diseases, so there is less use of healthcare system and less prescription use. Environmentally friendly due to less cans of formula and bottles. There's fewer missed days of work. When a child gets sick, usually somebody has to take them to the physician, and usually it's one of the parent, and that parent needs to take off work to do that, so there's less missed days of work if they're not so sick. Breastfeeding has been described as environmentally friendly. A 2015 report on the carbon footprint of infant formula in the Asia-Pacific region reported that the total greenhouse gas emissions from formula sold in just 6 countries in 2012 was approximately 3 million tons, which is roughly equivalent to a car driving 7 million miles or burning 3,000 million pounds of coal. More than 4,000 liters of water are estimated to be needed along the production pathway to produce just 1 kilogram of powdered formula. So before we start encouraging a woman to breastfeed, we need to know who can breastfeed. So I'm going to talk about some disease processes and infections and substances that a patient may be using. But I want you to keep in mind that mothers that are infected with some of these viruses and bacteria will be quite ill. And in addition to feeling bad physically, they will be sad and disappointed about being separated from their newborn and will need a lot of support, both medically and emotionally, to help them make a good milk supply. It's our job to help advocate for her and her family so she will have as good an experience as possible around her birth. Helping her make good milk supply will be one way she can feel connected to her child, even when she cannot be with them and hold them. So for HIV, in the setting where breastfeeding with antiretroviral therapy is recommended, the World Health Organization and UNICEF guidelines for optimal breastfeeding are the same as for those mothers and babies. Breastfeeding initiated within the first hour of birth, exclusive breastfeeding for the first 6 months, and continued breastfeeding for 2 years or longer. In 2019, the World Health Organization noted that consistent treatment is vital to preventing mother-to-child transmission of HIV. In the absence of interventions such as antiretroviral therapy, the risk of mother-to-child transmission of HIV during pregnancy, labor, delivery, and breastfeeding is estimated to be between 15 and 45%. With effective interventions during these periods, this rate can be reduced to below 5%. And in 2022, the CDC finally stated that for patients that achieve viral suppression during pregnancy, delivery, and the postpartum period, the risk of transmission through breastfeeding is less than 1%. So it's important that we discuss this with patients and we have shared decision-making with them at the time of delivery to figure out whether they're going to breastfeed or not. Patients who choose to breastfeed should have close follow-up. For patients who have infections with HTLV and Ebola, these women should not breastfeed and should not provide expressed milk to their infants. They should be not stimulating their breast post-delivery, and they may require suppression of lactation to feel more comfortable. For alcohol use, I do believe there's someone else talking about medications in mother's milk, and they may cover this in detail. However, in general, the highest levels of alcohol in the maternal blood are between 30 and 60 minutes after consuming. Moderate consumption, which is defined as 1 drink per day, is not known to be harmful, especially if the mother waits at least 2 hours after a single drink. For drugs of abuse, such as cocaine, PCP, heroin, and methamphetamine, we do not recommend breastfeeding because of the risk to the infant. And for marijuana, the current data are insufficient to assess effects of the infant to maternal marijuana use during breastfeeding, and therefore maternal marijuana use should be discouraged while breastfeeding. For a woman with brucellosis infection, she should not breastfeed while she's infected and has not been treated, and her breast milk should not be fed to the infant until she has been treated. She should work to maintain a milk supply during the time she's being treated, and then she can get back with her baby and feed the baby the breast milk when she is better. Again, Bobby Phillip, I believe, is going to be discussing medications and how to find out what medications a patient may be on and if they're safe with breastfeeding. For a herpetic lesion on the breastfeeder's nipple, she can breastfeed from the unaffected side and maintain a supply on the affected side. Because the baby's immune system is so immature immediately post-birth, we don't want the baby to be anywhere near that infected nipple. So although the milk may be safe, we just say pump and dump on that side. So for women with these infections, because both tuberculosis and chickenpox are transmitted through respiratory droplets, mothers and babies need to be separated immediately after birth, but the milk should be safe. Patients should express milk to feed the baby. That milk would be fed by somebody else. For tuberculosis, she can breastfeed when treated for a minimum of 2 weeks, and she is found to be non-infectious. For varicella or chickenpox, the mother needs to be separated from the infant and provide expressed breast milk until the lesions are crusted over. You may be surprised, but these patients can breastfeed and should breastfeed if they so desire. For mothers with an active hepatitis B infection, the baby will receive immunoglobulin and the vaccine right away in the hospital after birth and should continue to breastfeed. For hepatitis C, because there is no immunoglobulin or vaccine, we need to be careful about cracked and bleeding nipples, so it's very important to focus on the latch and get a lactation help right away in the hospital. However, there's never been a documented case of transmission of hepatitis C from mother to baby through breastfeeding. For mothers with opioid use disorder who are in a program and have had clean urines during their pregnancy, they should be encouraged to breastfeed. For mothers using methadone, very little of the methadone gets into the milk, about 1 to 2% of the mother's dose, and in most cases, it's undetectable in the infant's serum. There is no maximum therapeutic dose over which breastfeeding is contraindicated. There's less exposure while breastfeeding than during pregnancy, so breastfeeding may decrease neonates' withdrawal symptoms and improve outcomes. For Suboxone, the amount excreted into the breast milk is small and unlikely to have an adverse effect. And for antidepressants, you usually can find one that is safe with lactation. And again, I believe Dr. Bobby Phillips will be discussing how to find that information out. For tobacco use, parents should be encouraged to quit or decrease the number of cigarettes smoked. Counseling the patients or anyone smoking around the infant should be discussed. Maternal smoking is a risk factor for SIDS and may affect her milk supply by lowering prolactin levels. Nicotine is concentrated in breast milk. So the recommendations for parents are not to smoke near the infant, smoke outside, have a smoke-free rules for the car and home, change clothes or use a smoking jacket that's kept away from the infant, and wash your hands after smoking and prior to handling the infant. If a woman gets pregnant while she's breastfeeding, there's no contraindication to continue to breastfeed. However, sometimes the breastfeeding infant may notice a change in the flavor of the milk and may self-wean or decrease the amount of breastfeeding during pregnancy. But if she successfully breastfeeds through the pregnancy, she can tandem nurse the infant and the toddler. So for your elevator speech, did you know that investing in a workplace lactation program can yield substantial dividends for our company or hospital? There is a significant annual savings in healthcare expenses, including significant fewer prescriptions written and taken, and there are substantial savings due to reduced absenteeism of our employees. For the pregnant patients, I would suggest a plan of 3 to 5 prenatal visits to discuss specific breastfeeding topics. For the early breastfeeding visit, you may say, did you know that babies who are formula fed have higher rates of asthma, ear infections, lower rates of respiratory infections, childhood leukemia, obesity, and diabetes? And for you, mom, when you breastfeed, your risk of breast cancer and ovarian cancer, cardiovascular disease, osteoporosis, and obesity, and diabetes will also be lower. Also, you are likely to miss less days of work. The baby will need less prescription medications, and you will be in better touch with what's going on with your child and their health. For your medical students, residents, and colleagues, please use this What Every Physician Needs to Know course as a starting point for your educational series. We encourage you to steal and share. Thanks so much for joining me for this presentation on why breastfeed.